Hi, everybody. I'm Dr. Graham. I'm an orthopedic spine surgeon, and I'm happy to announce that I've joined Southeast Orthopedic Specialists. I am going to be working primarily at the Fleming Clinic, and that's where I'll see patients in the office, and I'm going to be operating at the St. Vincent's Hospital, Clay County. Thought I'd start off just giving you a little bit of background about myself. I got board certified in orthopedic surgery back in 2014. I went to college at William Jewell College in Kansas City, Missouri, and I also went to medical school in Kansas City. And I did my 5-year residency in Harrisburg, Pennsylvania. And my fellowship was 1 year. It was in Tampa, Florida. 6 months of that was at Moffitt Cancer Institute, where we did resection of complex neurosurgical tumors. And then the other 6 months was another part of spine, which is orthopedic spine. So we focused on deformities and degenerative spine. I have 5 kids. The oldest is 15, the youngest is 2. And I'm from Joplin, Missouri, which is in the southwest corner of the state. I am planning to provide services to patients 18 years or older, but I'm flexible to that. If there's somebody that's younger that has certain pathology, I would definitely be willing to take care of them. So I treat people with, they come in with back and neck pain, which is frequently associated with radiating arm and leg pain. And the reason they have this pain is sometimes they'll have disc herniations. They'll have what we call radiculopathies, and that's nerve pain that shoots below the knee due to a pinched nerve. Frequently, they'll have compression fractures. They may have neuropathic pain syndrome. They may have spinal stenosis, all of these terms you may have heard. I just thought I'd briefly touch on them. The disc herniation, a lot of people, don't really have a firm grasp of what that is. The intervertebral disc sits between the square vertebra and the spinal column. It acts to allow motion in the spine and also shock absorption. Sometimes they wear out though, and they'll bulge a little bit, and sometimes they'll herniate, meaning kind of like a jelly donut, that jelly will shoot out and it goes where it's not supposed to. And there's only so much room in there for the nerves. And so when you have a big piece of disc herniation, it causes the radiculopathy, the pinched nerve. So the treatment for that is, of course, conservative at first. We try to buy time, get you in physical therapy, sometimes steroid shots. But if it starts to cause weakness or if it doesn't respond to conservative treatment, then we'll operate. And that usually takes about an hour. We make a small 1-inch incision, detach the muscles off the bone, remove a little bit of bone, and we reach in there and grab the piece of the disc herniation that's pinching the nerves and pull it out. So that's usually an outpatient procedure. Spinal stenosis, I'm sure you've heard of. What is that? Well, that basically means pinched nerves. And why do the nerves get pinched? We have changes in the anatomy. You have discs that bulge. We talked about what the discs are. Well, they tend to bulge backwards, kind of like a flat tire, and that can encroach on that area where the nerves are. There's joints in your back that allow motion, that glide on each other, and kind of like a knuckle, they can enlarge. So if you've seen somebody with arthritis in their hands and enlarged joints, the same thing happens in the spine. And so as those joints get bigger and the disc bulges backwards, the area for the nerves closes off, kind of like a napkin ring effect. And so frequently patients will complain of an inability to stand very long or walk very far. And they almost always will say they can walk when they lean on the shopping cart. So if this sounds familiar, you might have spinal stenosis. Another thing people complain about is they can't stand long enough to do the dishes or cook. So after a while, this can really affect your quality of life. This is an MRI. I won't go into too much details, but you can see in the upper part of that picture on the right, there's plenty of room in there for the nerves. There's plenty of fluid around the nerve roots. But as you look in the lower part where the arrow is, you can see that napkin ring effect I was talking about, the changes in the anatomy, the bulging discs, the joints that are bigger, and there's a ligament that gets larger than it should be. And so the result of all that is the stenosis. And so frequently we can treat the stenosis with what's called a laminectomy. So if you think about like taking the roof off the house, when you remove the back of the spine, you make more room for the nerves and they're no longer pinched. Sometimes we can get away with just doing the laminectomy, but sometimes we'll have to do a spinal fusion. When the nerves are really pinched in certain spots, a laminectomy alone won't cut it. So we'll have to put hardware in there in the form of screws and rods. We'll have to remove the disc between the vertebra that we're trying to get to fuse. And I have an X-ray, then slide after this. But this just shows that to get the fusion, sometimes we'll make incisions on the back, sometimes we'll make them on the side, sometimes we'll make them on the front. There's just different ways to approach the fusion. This X-ray shows the screws and rods that we put in. This is a 1-level fusion, and that block between the vertebrae is called an interbody, and that just helps with the healing of the bones together. that hardware does stay in forever. A lot of people want to know that. Another common issue that we see is compression fractures. And so patients will come in and they had a sudden onset of back pain. It might have been a cough, a sneeze, sometimes just a bump in the road, or it might have been a fall. But they have they have a lot of difficulty standing upright, trying to get out of bed. They look stooped over. Sometimes they'll have a protruding abdomen and they fill up easy. They don't feel like eating and they get depressed. This MRI on the right shows you a compression fracture. You can see the other vertebrae are square like they should be, but the one that lights up is a wedge compression fracture. So it basically is crushed. And that causes a lot of micromotion in the spine when the patient gets out of bed to try to walk. So it feels good to lay flat in bed, which is exactly what we don't want in older people. So our goal is to try to get this to heal. So we don't have to operate on these. Sometimes if a patient says it doesn't hurt very much and they can live with it, then we just let it heal, and that can take 8 to 12 months. But if patients are debilitated, depressed, and in bed, we'll offer them a procedure called kyphoplasty. We make a little poke in the back and we use X-ray to advance a needle into the fracture, and then we fill it with cement. And basically it's like a cast on the inside of the spine that stops all that micromotion that causes the back pain. So it's not a fusion procedure. You're not losing any motion in the spine. You're just stabilizing it. Like I said, that procedure takes about 10 to 15 minutes and you go home the same day. You have a little Band-Aid on your back. But that's a very common procedure. Spinal cord stimulators are another option we have. These are a great option for what we call neuropathic pain syndrome, or patients that have had a big back surgery with screws and rods, and the last thing they need is more screws and rods, but they have terrible back and leg pain. And sometimes patients have terrible nerve pain and we get an MRI and there's just nothing that we can do to take pressure off nerves. And so this is a great tool to have on our belt. It takes about 30 minutes to implant. They do a trial at first, so they may put a little needle in your back and put a wire, and you would have that in there for about a week, and you want to figure out if it's going to work or not. And most of the time it does. Patients are very upset when we have to pull it out because the trial is temporary. It comes out, and then the patient would see me and we would do the permanent stimulator. Like I said, about 30 minutes, 2 incisions, and you go home the same day. Basically, the stimulator sits on top of the spinal cord and stimulates it such that it inhibits that sensation of pain from reaching the brain. So, compared to some big fusion surgeries, this is a great minimally invasive option to help, especially when there's no other options. Here's another picture of the lead that we place in there in the thoracic spine next to the spinal cord. And then the battery just looks like a pacemaker. It's real thin and it sits above your belt line. And so I already mentioned this, but I'm going to be doing my clinic on Fleming Island. There's the address there, and I'll be operating at St. Vincent's, Clay County. So I sure appreciate your attendance tonight. And if there's any questions, I'd love to answer them for you. That would be nice. That always helps. But frequently, patients will just come in with an X-ray and they won't have an MRI or advanced imaging, and it's no big deal. We'll do an exam, talk to them about what to expect, and then treatment protocol, and we'll get the MRI ordered. But in order to make any definitive decisions about where we're going to go in terms of surgery or physical therapy, we have to get that MRI so we can look at the nerves and see, are they pinched? How bad is it? How many levels? And that kind of dictates our plan. No, it'll work long term. Yeah, no, it doesn't keep you from developing other pathology. So it'll help with the nerve pain today, but that's no guarantee that you won't have things like a compression fracture or developing stenosis in the future. But it is nice to have it in there. A lot of patients come in with burning, radiating left leg pain, and when they get the stimulator and it'll help with that. And let's say 10 years down the road, now they have burning right leg pain. They can adjust where that stimulator stimulates, make it go down the right leg. So. That usually depends on the amount of pain that you're having. If you have any weakness, how bad your quality of life's affected. Frequently, we try for 6 weeks. So we would do things like epidural shots, steroid shots in your back, physical therapy, activity modification, weight loss, anti-inflammatories. We'd try all of that for at least 6 weeks. The exceptions being those people that hurt so bad they can't get anything out of physical therapy. Sometimes it just makes it worse. Other exceptions, weakness. Some people get a foot drop, or they can't bear weight, their knee gives out on them, or they start to get atrophy. And then there's other surgical emergencies that we would just, try to operate sooner rather than later. But in general, we try for about 6 weeks. Back pain is always very difficult. Great surgical candidates frequently have back and burning, radiating leg pain because a nerve is pinched. We do see a lot of patients with back pain, and it's frustrating for patient and doctor. Typically, the best options there are weight loss, activity modification, physical therapy to try to figure out, what's going to help it. That's not surgery, because sometimes surgery for back pain can make it worse. And so, if you can find things in therapy like heat, ice, massage, TENS units, traction, that's ideal for back pain. So I do a lot of laterals, and they have their indications. They're a great option to have when you've got a patient that has had prior surgery and they have a lot of scar back there. So the anatomy is very difficult to identify and work through, and it actually creates a lot more risk when you have all the scar. And so, a great indication is to go from the side and separate everything and put a tube onto the spine. And now you're in virgin tissue, so there's no scar. Plus you can access the disc a lot better. And so all that disc that we talked about, that shock absorber, that all comes out, and then you put a spacer in there to help it fuse. And that spacer also tends to separate those square vertebrae, which opens up the nerve hole. And so you've just accomplished what we call an indirect decompression, all while staying out of the scar. And so if you don't have that option, if you don't know how to do a lateral, then you'll have to do it all from the back through the scar. And it's more risky, and you can't accomplish the decompression that you need to. I think it's worth a try. I don't think you're really, you're not burning any bridges. It's not you're not fusing it. So it's definitely worth a try, but you do have to know the pain is, if you get pain relief, it may not be forever. But that's the name of the game, is to try everything other than surgery first. So certainly worth a try. If it worked the first time, talk to your pain doc and maybe trying it again. It depends on how much pain you're having, and if you have any of those surgical indications that we talked about. If you have weakness, if your pain is intractable, or if you can't control it with medicines and activity modification, it would depend on what the MRI looked like and just how pinched the nerves are. A mild scoliosis in itself, we can leave alone. But if you have terrible nerve pain and the nerves are very pinched due to those bulging discs, you might be a great candidate for surgery.